All right. Hi, everyone. I'm Dr. Ed Evangelista here with Dr. Chris Rogers from San Diego Orthobiologics Medical Group. Today, we're going to be talking about management of meniscus tears in the knee, to cut or not to cut. First, I want to give you a little background on what we do. So as most of you know, Dr. Rogers and I are both physiatrists. So we're not physical medicine and rehabilitation specialists. So we specialize in the non-surgical management of orthopedic and spine conditions. Earlier in our careers, both Dr. Rogers and I worked with large orthopedic groups. So we've worked with several orthopedic surgeons. I worked with an orthopedic group in Orange County for 20 years where we had 8 to 10 orthopedic surgeons, and I was the non-surgical orthopedic specialist. And then Dr. Rogers had a similar practice for 17 years with the orthopedic group next door here in Carlsbad. And he was there for 17 years, and eventually we broke off and started to focus our practice on non-surgical management using orthobiologics. So we've treated a lot of meniscus tears over the years, and it was actually nice to collaborate closely with surgeons, especially in cases where we thought surgery may be necessary. So we really learned what the surgeons like to do from a surgical standpoint. So today I'm going to focus on the medical evidence and literature regarding optimal management for meniscus tears, but also share what we've seen in clinical practice working with a lot of these orthopedic surgeons. So we're going to start first going over the anatomy. The knee joint is the articulation between the femur bone on top with the tibia bone on the bottom. And then you have your kneecap or patella in the front. And then around the ends of the bone, you have your articular cartilage here, here, and here. And then in between, you have these two crescent-shaped pieces of fibrocartilage called the menisci, here and here. On the inner part of the knee, you have your medial meniscus, and then the outer part of the knee is the lateral meniscus. The menisci cover about 70% of the joint surface, and they function to provide cushioning or shock absorption. So they help to protect that articular cartilage. They help with load transmission and help to improve stability in the joint. Blood supply of the meniscus is going to be at the outer 1/3 of the meniscus, known as the red zone, where there's good blood supply, whereas the inner 2/3 of the meniscus is relatively avascular, so that lacks blood supply. And that's important with regards to healing. So tears that occur in the outer 1/3 of the meniscus, where there's good blood supply, have better capacity to heal and may be more amenable to surgical repair versus tears that occur on the inner 2/3 may not heal. They have poor capacity to heal and may not be amenable to surgical repair due to the inadequate blood supply. Tears of the meniscus can occur, and they can be categorized as being either traumatic. So a traumatic tear occurs with an acute traumatic injury, such as a twisting or sudden change of direction. It can commonly occur when somebody tears their ACL. You can tear the meniscus at the same time. Or you can categorize the tear as being a degenerative tear. So a tear that occurs with aging and wear and tear. As that meniscus tissue degenerates with normal aging, it can tear. Signs and symptoms of a meniscus tear include a pop at the time of the injury. So if during an acute injury, you're going to feel that pop. They'll have joint line pain, especially with twisting, joint line tenderness on exam. They'll have swelling in the knee joint, a feeling of instability, and they can experience mechanical symptoms, so catching, popping, clicking, locking, and restricted motion. This locking can occur if that meniscus tear is unstable and it can displace. So that meniscus tear can flip and get caught in the joint and cause that knee joint to lock. So that patient will have inability to fully straighten the knee when that happens. There's different types of meniscus tears depending on the location and morphology. We won't go into this in too much detail. Diagnosing a meniscus tear, your MRI is going to be your gold standard to visualize the meniscus. You can't see the meniscus on X-ray. We can see the meniscus on ultrasound, but we can only see the peripheral part of the meniscus. So MRI is really the best test to visualize the meniscus pathology in its entirety. Now, most of you know that asymptomatic meniscus tears found on MRI are very common. This has been well studied. It's going to be more common with older age and in knees with more arthritis. So you really have to correlate the MRI with clinical symptoms because we see these tears all the time that are incidental and not causing any symptoms. Prevalence of asymptomatic meniscus tears on MRI can be anywhere in young patients, just 5%, but in older patients, up to 67%. 67%. My daughter, 10-year-old daughter,
Oh no.
I promised her I would add that into the talk today. So, um, non-surgical management of meniscus tears is going to be initially the treatment of choice for the majority of meniscus tears, non-surgical management, especially for degenerative tears. So non-surgical treatment is going to include relative rest, modification of activities, physical therapy, non-steroidal anti-inflammatories for pain and inflammation, occasionally a cortisone shot for pain and inflammation. And the goals of non-surgical treatment will be pain reduction, improving function, return to sport, and even potential healing. So if you have a small tear at the outer peripheral 1/3, that does have some capacity to heal and doesn't need surgery. So let's talk about surgical treatment for meniscus tears. There's two main surgeries. One is the arthroscopic surgical repair. That's when the surgeon goes in and tries to actually sew that tear back together and repair it. The other surgery is the arthroscopic partial meniscectomy, where the surgeon goes in and basically shaves off the damaged tissue, trims off the area of the tear, trying to preserve as much meniscus as possible. So surgical repair, this is going to be considered for the acute traumatic meniscus tear in a young active patient with an otherwise healthy knee joint. Whether or not they're a candidate is going to depend on the location, type, and extent of the tear, their age and activity level. Repair is typically not performed for degenerative tears because that degenerative tissue is not going to be strong enough and amenable for a successful repair. Also not often done, usually never done for patients with advanced arthritis. Those are patients who are going to go have knee replacement rather than a meniscus repair. The goal of the surgical repair is to preserve the meniscus because that's really going to be best for the long-term health of the joint to prevent future arthritis. Timing of repair after acute traumatic tear. This has been studied. This was a nice systematic review published in the American Journal of Sports Medicine, September of 2025, so just recent. This looked at 35 different studies, and they tried to compare outcomes of early versus delayed meniscus repair. The authors concluded that meniscus repair preferably should be done within 8 weeks of the injury, possibly even within 3 weeks. So they saw that the failure rate, if the surgery was done before 8 weeks, was 10.2% versus if they waited until after 8 weeks, it was higher, it was 18.7%. So that ideal window is probably in that 3 to 8 week window to have a better chance at a successful repair. If you wait too long, delay it, then it may not be as successful. There are a couple of instances where we send patients to the surgeons earlier for surgery. One is the displaced meniscus tear with a locked knee joint. The most common is going to be your bucket handle tear. So you can see the picture on the bottom right. This is an example of a bucket handle tear. We call it this because the tear morphology is analogous to a bucket handle. So that part of the meniscus can flip, kind of like a bucket handle. And if it flips and displays it into the knee joint, it will cause a locked knee joint. So we see these patients that come in with an acute injury and they can't straighten their knee all the way. And these patients, you don't want to try to force the knee into extension because you can make the tear worse, and it could be irreparable if you do that. So we send these patients to the surgeons right away. So hopefully the surgeon can go in arthroscopically, put that meniscus back into its proper location, and then repair it. The other situation where we like to send patients to the surgeons earlier is with the complete root tear or avulsion. So if there's a tear at the meniscus root, as seen on the picture on the bottom right, if it's a complete tear, that can render the entire meniscus unstable. So this is a situation where we like to send the patients to the surgeon to see if they can repair that tear, because this morphology of tear has been associated with rapid progression of arthritis if it's not fixed. So these are situations where we send the patients to the surgeons a lot earlier rather than later. And then you have your arthroscopic partial meniscectomy. This is the other surgery done for meniscus tears. This is considered for patients with persistent pain or mechanical symptoms who have failed conservative care and where the tear is not deemed to be repairable. So your degenerative tears usually fall into this category. In this surgery, the surgeon goes in arthroscopically, and that damaged meniscus tissue is resected or trimmed, trying to preserve as much of the healthy meniscus as possible. And this is going to be a much more common surgery compared to the repair. Now we're going to kind of talk about the main differences between the meniscus repair versus partial meniscectomy, because we see a lot of patients who don't, they've had knee surgery. They're not sure if it was a repair or if it was a meniscectomy. But I think the differences are important because this has some ramifications on recovery as well as the long-term health of the joint. So both surgeries are done arthroscopically. So small incisions that go in with the scopes, and usually 2 or 3 portals, and they do the surgery through an arthroscopic technique. With the meniscus repair, the recovery is going to be a lot longer because the surgeon is going in and trying to sew that meniscus tissue back together, and you need time to get that to heal and to take. So these patients are typically non-weight bearing for 4 to 6 weeks after the surgery. So you're on crutches for 4 to 6 weeks. And then it's a slow recovery after that to allow this repair to heal. So return to sport is not until 4 to 6 months. Versus with a meniscectomy, they're just shaving off that damaged tissue. So you're weight bearing right away, right after the surgery, you're putting weight on it right away, and return to sport's a lot faster. So 4 to 6 weeks, then you're back to sport typically. Failure rate inherently is going to be a lot higher with the meniscus repair because a lot of times that surgeon goes in and tries to sew the tear back together, but there's going to be certain, high percentage that will fail and they don't take and may need another surgery later versus the meniscectomy. You're not sewing anything together, so you're not trying to get the repair to heal. So these patients, the re-tear rate's a lot lower. Now, the main advantage to the meniscus repair is that you're preserving the meniscus tissue. So that's especially important for these cases in young patients with a healthy joint. If you can preserve that meniscus tissue, you're decreasing the chances of developing early arthritis over time. Versus in the meniscectomy, you're taking out that meniscus tissue. Sometimes even 25 to 50% of that meniscus tissue can be removed, and that's going to lead to a higher chance of arthritis down the line. So it's not the best thing for long-term joint health. Meniscus repair is much less common compared to meniscectomy. I would say probably over 90% of the patients that we see who have knee arthroscopy are having a meniscectomy and not a repair. Is that your experience as well, Dr. Rogers?
Yeah, a lot of patients will be told or believe that they've had a repair, but in reality, they've had the meniscectomy, which is the more common procedure. And I mean, when it's necessary, it's necessary. The other thing I will add is a lot of patients who have a more degenerated meniscus who undergo partial meniscectomy, they've only solved part of the problem, right? They've solved the mechanical part, but a lot of these patients also have concomitant thinning of the articular cartilage. So not the meniscus cartilage, but the cartilage on the end of the bone. And and so that's basically osteoarthritis. And I think you're going to talk about that in a little bit here.
Yeah, yep. So the arthroscopic partial meniscectomy is really one of the most common orthopedic surgeries that's been performed in the past 20 years. But it's really come under intense scrutiny, especially about 15 years ago. There's a lot of new data that came out that really showed that the surgery is really controversial for a variety of reasons. One, a lot of the studies have shown that it's not proven to be better than physical therapy or sham surgery. Two, as I mentioned, it can lead to accelerated progression of osteoarthritis. Three, it's pretty well established that it's not a good surgery for patients with moderate to severe knee arthritis. These patients don't do well with the surgery. It actually makes the problem worse and can accelerate the need for going to knee replacement. And then four, the surgery is often performed for mechanical symptoms, but so there's some data showing that these symptoms may not necessarily be specific to a meniscus tear. So let's review some of the data here. So this was a study published in the British Journal of Sports Medicine, March of 2019, looking at self-reported mechanical symptoms. And they were trying to see whether or not these mechanical symptoms were a reliable indicator of a meniscus tear. So this study looked at 817 patients who underwent knee arthroscopy for a suspected meniscus tear. At the time of surgery, 641 had a tear and 176 patients did not have a tear. And then they looked at the mechanical symptoms that the patients reported prior to the surgery, specifically catching, locking, and inability to fully straighten the knee. And they found that these symptoms, the mechanical symptoms, were equally prevalent in patients with or without a tear. So there were a lot of patients reporting catching and locking, but they didn't have a meniscus tear. So these authors concluded that self-reported mechanical symptoms have limited value when considering meniscus surgery. So we can't always go based on these symptoms that there's a meniscus tear causing the issue. What about arthroscopic partial meniscectomy and worsening osteoarthritis? So there are several studies that have been published documenting this phenomenon. These are just two of them that I'm demonstrating here. One was published in European Radiology in January 2017, entitled "Partial Meniscectomy is Associated with Increased Risk of Incident Radiographic Osteoarthritis and Worsening Cartilage Damage in the Following Year." And then this other study published in the American Journal of Sports Medicine, July 2022, entitled "Increased Joint Space Narrowing After Arthroscopic Partial Meniscectomy, Data from the Osteoarthritis Initiative." Both these studies concluded that arthroscopic partial meniscectomy is associated with worsening osteoarthritis compared to patients undergoing non-surgical management.
I think the other interesting point is that those were radiographs. So we're talking X-rays, and I think all of us realize that MRI is probably the more sensitive test. So if you were seeing enough degeneration to be evident on X-ray, that is significant degeneration.
Yeah. And then what about meniscectomy compared to meniscus repair? This has been studied as well. These are two systematic reviews that compared patients who underwent partial meniscectomy versus patients who had meniscus repair. And they looked at the rates of osteoarthritis progression after these surgeries. Both these published studies concluded that arthroscopic partial meniscectomy is associated with faster progression of osteoarthritis comparing to patients undergoing meniscus repair surgery. So meniscus repair is really the preferred surgery if you're trying to minimize progression of arthritis. And again, that makes sense. If you can save that meniscus tissue, that cushioning for the joint, then you're going to help prevent, slow the progression of arthritis, versus if you take out half that meniscus, then that's going to accelerate the chances that you're going to have accelerated arthritis.
I think fortunately this is well recognized by the surgeons that we've worked with. They are very good at sparing as much tissue as possible. It's not like the old days where, maybe 20 years ago, where in some cases the entire meniscus was removed. And then just a few years after that surgery, patients would go on to have a need for joint replacement.
Yeah.
So we are seeing a change. We are seeing fewer patients getting arthroscopy. We're seeing those that do get arthroscopy have more less invasive, less tissue removal. But it's interesting, these studies that you're sharing with us are actually pretty recent studies. I mean, they're not talking about, the 1990s data. They're not talking about the 2020 data. These are recent, still showing even with the more conservative approach that is a challenge.
Yeah, and I think in Europe, the guidelines in Europe, they're even more aggressive at doing meniscus repairs, even in these patients who have, some arthritis. I think more aggressive than the surgeons in the US. But definitely a trend. If you can really save the meniscus and repair it, that's ideal. But it's a longer recovery. Sometimes the repair doesn't take.
Right.
Then what does Google AI think? A lot of us are using Google and AI for our medical information. Well, Google agrees. I asked it. They said, yes, research strongly suggests that partial meniscectomy can accelerate progression of knee osteoarthritis and worsen cartilage damage within a year.
Google knows all.
Now, this was a landmark study comparing arthroscopic partial meniscectomy to sham surgery, so placebo surgery. This was a huge landmark study known as the Fidelity Trial. It was published in the New England Journal of Medicine in December of 2013. This was a double-blind randomized controlled trial, 146 patients with knee symptoms consistent with a degenerative meniscus tear and no osteoarthritis. So these were the ideal patients for whom the surgery should work. They had an isolated meniscus tear without any arthritis, so the surgery should be successful for these patients. And so these patients were randomized to receive the arthroscopic partial meniscectomy or the sham surgery. It was blinded, double-blinded, so the patients didn't know if they had the true surgery or the sham surgery, and the surgeons didn't know until the time of the surgery. So the surgeons, all these patients underwent diagnostic arthroscopy to confirm the tear. And then at the time of surgery, the surgeon was given an envelope to tell the surgeon what that what group that patient was assigned to. So if the patient was assigned to the meniscectomy group, the surgeon would go ahead and do the actual surgery. If the patient was assigned to the sham surgery group, then the surgeon would put the arthroscope into the knee joint, but he didn't do any surgery. So it was actually a true placebo surgery. And so they followed these patients for 12 months, and they found that both groups had improvement, but there was no significant difference between the groups and outcomes. So the placebo surgery group did just as well as the true surgery group. And so they concluded that arthroscopic partial meniscectomy for a degenerative meniscus tear without osteoarthritis is no better than sham surgery. And this was a huge, this really called into question this surgery and why it's being overutilized and done so much. Is it really necessary? And then these same patients were followed up to 5 years, and the data was published again. And again, at 5 years, they saw no difference between the groups in outcome, but they saw that there was a consistent, slightly increased risk of progression of radiographic knee osteoarthritis in the meniscectomy group compared to the sham surgery group. So not only did the surgery not help the patients anywhere than the placebo surgery, but it increased their chances of some arthritis down the line. Now, what about comparing arthroscopic partial meniscectomy to physical therapy? There are several studies that compare this as well. This was another landmark trial called their Meteor trial. It was a randomized controlled trial looking at 351 patients, age over 45, with a meniscus tear with mild to moderate knee arthritis. So this is a little more representative of what we see in clinical practice. So these patients were randomized to receive either the arthroscopic partial meniscectomy with postoperative physical therapy versus just physical therapy alone. And at 6 and 12 months, they saw that both groups had improvement, but there was no significant difference in the outcomes between the groups. So both groups did the same. However, there was a 30% crossover rate. So 30% of the patients who were in the physical therapy group weren't satisfied with how they were progressing. They opted to cross over and then have the surgery during the study period. And then they again published their data at 5 years. And again, pain improved considerably in both groups. So both groups improved, but again, there was no significant difference between the groups in outcome. 7.1 of the patients in the study did go on to have knee replacement surgery, but they saw that this was 4.9 times higher in the patients who had the arthroscopic partial meniscectomy. Again, reiterating the fact that the surgery can lead to accelerated arthritis and potential need for earlier knee replacement. And then the same patients in the Meteor trial were evaluated by MRI at baseline and at 18 months, looking specifically for worsening cartilage loss. And they did confirm again that there was worsening cartilage damage in 60% of the patients who had the arthroscopic partial meniscectomy versus only 33% in the physical therapy only group. Again, reiterating the same concept we're trying to relay.
Yeah, and it's hard to know if that worsening cartilage damage is due to the fact that they had surgery or due to the fact that they were so severely injured that they needed surgery is probably multifactorial, but I think it's pretty clear in those large data sets that those trends are holding up across multiple studies.
Yeah. And then, so there are several other studies that have compared arthroscopic partial meniscectomy to conservative care, physical therapy, sham surgery. We're not going to go through every study, but these are three nice systematic reviews. So these authors looked at all the data that's been published and concluded basically the same thing that we've seen already. This systematic review from 2023, the authors concluded that arthroscopic partial meniscectomy and physical therapy result in similar outcomes for degenerative meniscus tear. 2018 systematic review, these authors concluded there was no compelling evidence to support arthroscopic partial meniscectomy versus physical therapy for a degenerative meniscus tear. And then the study in 2017, they also concluded arthroscopy was not better than conservative care in the long term for pain and function. However, these authors felt that there was a small benefit for arthroscopy in the short term. And there was one study I came across that did show that the surgery group did better at the 6-month and 1 year mark compared to the non-surgical group. But then at 3 and 5 years, that difference was negated and they were pretty much the same at 3 and 5 years. But that first year, there was some better improvement in the surgical group compared to non-surgical group in one study. Now, what about patients with degenerative meniscus tears with knee arthritis? This is what we see most commonly in clinical practice. We see patients with arthritis and they have meniscus tears as well, degenerative meniscus tears. A lot of us in the scientific community believe that the degenerative meniscus tear is really just an early sign of knee osteoarthritis, and it's part of the disease process. So if you look at patients with knee osteoarthritis, meniscus tears are present in 60 to 90% of patients with knee OA. And there's going to be a higher prevalence of these tears with higher age and with more advanced arthritis.
I think it's
And
important to point out, I'm sorry, I didn't mean to cut you off.
oh,
Uh, yeah, I think it's important to point out that, there's a big difference between, a 20 or 30-year-old athlete who twists their knee and tears their meniscus versus this scenario, which is, yes, it's chronic repetitive stress to the joint over years. Usually these people are born in their 50s and 60s and later. But this is a more than just a simple soft tissue injury, a trauma to the tissue. It may have been started by that, but you now have an alteration of the biologic environment. And what I mean by that is your immune system is in some way causing chronic inflammation in the joint. And unlike rheumatoid arthritis, which is an autoimmune disease where the immune system is, directly attacking the tissue, in a way, osteoarthritis is doing the same thing, where you have the white blood cells secreting molecules, we'll just call them, that are enzymes that degrade cartilage. And it doesn't care if it's articular cartilage, like you see there, or cartilage and fibers in the meniscus. It's causing the slow degradation and it's impairing its ability to regenerate itself. So this is a different animal. This is not, which is why it's more amenable to a biologic therapy as opposed to a surgical approach, at least with regard to the meniscus.
yeah. And you can never tell if the pain is coming from the meniscus tear, the damaged cartilage, or both. It's really both that we're treating. We're treating the whole disease, not specifically aimed at trying to heal these degenerative meniscus tears. So, what is the ideal treatment for knee osteoarthritis with degenerative meniscus tears? The best injection therapy that we believe is platelet-rich plasma, or PRP. To review, PRP is where we draw a sample of a patient's blood. We concentrate the platelets out of that blood sample using a centrifuge, and then we inject the concentrated platelets with some plasma into the knee joint. Once injected, the platelets start to activate and release growth factors to stimulate that biologic effect that we're trying to do. So what is it doing in the joint? It's improving the joint microenvironment, reducing inflammation. It's helping to reverse that toxic joint environment. So it's reducing harmful proteins and cells that are causing pain and cartilage loss, promotes healing of injured areas of cartilage bone and potentially the meniscus. We know it's effective for arthritic pain. And by reversing that toxic joint environment, we can slow that degenerative process. So it does have a chondroprotective effect. And again, we're treating the disease. Our goal is not necessarily to heal these degenerative meniscus tears.
We'll get there. We'll get there. We'll get to the point. I mean, there's research being done in this space where a, a variety of different recipes, I call them. So using cells or cellular molecules in different combinations, maybe genetically modifying the cell, to replicate the healing mechanisms, but in a more potent way.
Yeah. And so PRP for knee arthritis has been extensively studied, numerous randomized controlled trials. These are all systematic reviews and meta-analyses of mostly level 1 data, mostly randomized controlled trials that looked at using PRP for knee arthritis, comparing it to other injection treatments. And all these systematic reviews concluded that PRP is superior to cortisone, hyaluronic acid, saline, and placebo for the treatment of knee osteoarthritis. So really the best treatment for knee osteoarthritis. Now, what about using PRP specifically for meniscus tears? There are several studies that looked at this in particular. This was a nice systematic review published in the Journal of Orthopedics in March of 2024. They looked at 10 different studies that specifically looked at using PRP injections for meniscus tears. And they found that most studies demonstrated that PRP treatment resulted in improved pain and function at 3 months and sustained for 1 year. At the studies that looked specifically at healing, they found that 30 to 70% of patients showed radiographic stability, so the tear didn't get any worse, and 40 to 60% actually showed interval healing of these meniscus tears in some of these studies. They found that there were lower failure rates, greater arthroscopy-free survival in the PRP patients compared to controls. And most consistent improvements were seen with patients who had a series of three PRP injections or where the platelet dose was greater than 5.5 billion. So decent amount of data showing that PRP can be used for meniscus tear and even promote healing.
You bring up a good point there. That dose is critical. There's certain things that after 25 years of practicing medicine are pretty obvious. Catch the injury as soon as you can. The earlier the treatment, the better. Maybe someday we'll even prevent injuries, and prevent osteoarthritis. But for now, the sooner we catch you, the better. The other is make sure you have an adequate dose. If you're treating, it doesn't matter if you're prescribing Tylenol or anything else, the platelet dose has to be adequate. And the studies are now unequivocal that if you don't have an adequate platelet dose, you're not going to see an adequate response to PRP therapy, which is why we have a cell counter in our lab, and every PRP sample goes through that quality control testing prior to being administered to the patient.
Yeah. And then this was a specific study. It was one of those studies that was reviewed in that systematic review, but I like this study because it was looking at the primary outcome was looking at healing of the meniscus tear. So this was a randomized controlled trial looking at 72 patients with a chronic meniscus tear. And these patients underwent meniscus trephination. That's a procedure where the meniscus is basically needled to increase blood flow to that meniscus to simulate healing. So the patients were randomized to receive meniscus trephination with a PRP injection or meniscus trephination alone without PRP. And again, the primary outcome was they were looking for healing of these meniscus tears on MR arthrography at 33 weeks. So the best test to really see if that meniscus tear healed. And they found that the healing rate of the patients who had trephination with PRP was 60%. 11 fully healed and 4 partially healed out of the 25 that were evaluated. And then the patients who had trephination only without PRP, the healing rate was only 42%, 7 fully healed and 4 partially healed out of 26. They also saw that the arthroscopy-free survival, so the time that patients were able to avoid arthroscopy, was 92% in the PRP group, 72% in the trephination-only group. And then significant pain improvement also showed 65% of patients in the PRP with trephination group had significant pain improvement compared to only 39% in the trephination only group. So pretty good data showing that PRP can assist with healing of these meniscus tears. One other study we're going to go over is this using microfragmented fat. So using a patient's own fat tissue or adipose tissue for healing or to help meniscus tears. This is a procedure where we do a liposuction procedure. We obtain the patient's fat. The fat has your mesenchymal stem cells, your adult stem cells. We process it and then inject that into the knee for arthritis or meniscus tears. We use it for tendons, but I think it has promise for treating meniscus tears because we believe it has more robust healing capacity and regenerative capacity compared to PRP, but it needs to be more studied. This was just one study with 21 patients with knee arthritis and a meniscus tear who failed conservative treatment. They had the MFAT injection into the joint and into the meniscus, and they had significant improvement in pain and function at 1 year. But we need more studies to confirm that it's really better than PRP and the other treatments. So take-home points. One, we know that a high percentage of meniscus tears found on MRI are asymptomatic. So we always need to correlate the MRI findings clinically. We see patients with tears on the inside of the medial meniscus, but their pain's on the outside. So that tear is not symptomatic. So always correlate clinically. Two, there's definitely a trend to preserve meniscus tissue when possible. So consider surgical repair for young patients, active patients with a traumatic tear, if that tear is repairable. Again, that 3 to 8 week window is usually when you want to try to get those patients in for surgery. The other surgical indications include that displaced bucket handle tear with a locked knee joint or the root avulsion.
Yeah,
In
I would say also
patients,
large flap tears
oh
probably
yeah,
also I would consider.
yeah.
Yeah.
And then if a tear is not deemed to be repairable and they don't have significant mechanical symptoms, really try to avoid meniscectomy surgery unless you've really exhausted all conservative measures, because we know arthroscopic partial meniscectomy is associated with accelerated joint arthritis. That's been well documented in the literature. Literature also clearly shows that arthroscopic partial meniscectomy is not superior to placebo or surgery or physical therapy for the treatment of degenerative meniscus tears. So non-operative treatment should be attempted first. I think there was a time many years ago where patients go straight to our arthroscopic meniscectomy, but now we know that's not the right treatment. So non-operative treatment first for these degenerative meniscus tears.
Yeah, I was an athletic trainer at UCLA in the 80s, and any football player who tore their meniscus went off to arthroscopy. That was the thing.
Yeah, yeah.
Not the case anymore.
Yeah. And then we like platelet-rich plasma for your patients with the knee arthritis with degenerative meniscus tears. Again, we're treating the disease, the osteoarthritis with these meniscus tears. It works well for these patients. And then I also like using PRP for meniscus tears without significant knee arthritis, especially if the tear is not deemed to be repairable, patient's not willing to have a repair and undergo that rehab and that recovery, or if patients just have pain without any true mechanical locking, then I think these are great candidates for PRP because we've seen that PRP can potentially promote healing and stability of the tear. So if we can help these patients clinically and they get back to their sport, even if that tear is not completely healed, we've helped them avoid a meniscectomy, which I think is a win in the long run.
Yeah, agreed.
All right, that's about it.
A lot of these patients, when you look at someone with pain, the MRI shows you one thing, but sometimes their pain is due to something else. So, in the case of an unstable meniscus, and you see that on physical exam, sometimes we'll see it on ultrasound. We'll ultrasound the meniscus and move them through different motions, and you can see that thing moving around. That's a different animal than, say, the person who has a stable meniscus, who has some degeneration or some tearing of it, and it's really just a chronic inflammation of the joint. I never really thought about it, but back in the day, we used to just inject cortisone and patients would get symptomatic relief. Well, all we were doing, we weren't healing anything with the cortisone. If anything, we might making it worse. But we were decreasing the inflammation, which is where a lot of the pain was coming from. And so that's what PRP and MFAT and some of these other biologics that we use do. They're very potent anti-inflammatories in addition to their healing capacity. So again, I think it's important to identify the cause of pain. Some patients their cartilage damage is so severe you can start to see changes in the bone. You see bruising, edema in the bone on the MRI. That's a whole different type of animal that we have to treat differently. For those we might use behind me, you see the shockwave. We use
Yeah,
shockwave for bone lesions. So sometimes multimodal therapies are necessary. Sometimes you need to combine PRP with shockwave therapy, with physical therapy to make sure you're addressing all the causes of pain to get the best possible outcome.
yeah.
Looks like we have some questions.
Right.
The first question is, can I get a copy of the recording? Yeah. So we record all these. By the way, Dr. Evangelista, thank you. That was a great presentation as always. Always appreciate seeing those clinical studies and how you present them. We record these. Are we recording this one?
Yeah, yeah,
Okay.
we're recording it and it should be, we should hopefully get this onto our YouTube site within the next 2 to 3 weeks.
Okay.
Yeah, hopefully sooner than that.
Yeah. And for those of you who are familiar, you can get to our YouTube channel a couple different ways. The easiest way is just go to YouTube, the website, and type in San Diego Orthobiologics. I think we have over 80 or 90 videos there that you can watch that we've done over the years. The other way is to go to the SDOMG website. So our website, and on the upper right, I think there's a little button that you click and it takes you to the YouTube channel. So both of those are available to you at any time you want to learn more about the work that we're doing. This question says, this one's for you. I missed the first part of your presentation. How much stem cell comes from adipose stem cells? Well, we didn't say that. So what's the answer?
How
Um,
much? Yeah, that's
yeah,
you're the expert on stem
I knew
cells.
you were okay. So first of all, a little history. The first mesenchymal stem cell, so the stem cell that we all talk about, the adult stem cell, not the embryonic stem cell, but the stem cell that's in our adult bodies, was identified in the 80s by Dr. Arnold Kaplan, and he discovered it in the bone marrow. So much of the research on mesenchymal stem cells in orthopedics is on the bone marrow stem cell. However, in the last, I would say, 2 decades, the number of studies that look at the mesenchymal stem cell derived from other sources, predominantly the fat tissue, I think has now eclipsed the bone marrow literature. And so Dr. Evangelista knows that adipose is near and dear to my heart because no one ever fights me when I say, can I take 4 tablespoons of fat from you? Because it is a rich source of stem cells. Matter of fact, if you were to take 1 tablespoon of bone marrow tissue, you would find that you could count about 50,000 mesenchymal stem cells in that tablespoon of bone marrow. But if you took an equivalent 1 tablespoon of adipose tissue, you could find up to 1 million mesenchymal stem cells. So many, many more cells in the adipose tissue. Now, there's different ways to repair all these things, all these tissues. Most of what's being done in the United States is, I would characterize as not a stem cell treatment, but as a tissue transplant. So when we do the microfragmented adipose tissue or the bone marrow aspirate concentrate tissue procedure, we're removing bone marrow tissue, we're removing fat tissue, and then we're injecting that into your knee joint, for example. If you want to get high, remember I said dose is key. If you want to get a higher number of stem cells, you don't want 50,000 from your bone marrow. You don't want 1 million from your adipose tissue. If you need tens of millions of stem cells, then that requires growing the adipose tissue stem cells, the mesenchymal stem cells in culture. And that has to be done in a lab that is supervised by the FDA. And therefore, none of this is yet FDA approved until they're proven to be safe and effective. And you can watch some of our other lectures, and we talk more about that. So there's many different types of treatment. It's important to know which one you're asking about.
Okay, what is your opinion about soft wave versus shock wave? Uh,
Oh,
yes.
I should have asked Adam. We had Dr. Tenford visiting from Harvard this weekend. I had dinner with him on Sunday, and he is the guru. I should have asked him his opinion. He is actually using the device that you see right coincidentally behind me. Neither one of us work for the company. We just believe in their product. I think there's good evidence that soft wave has some difference in the physics, maybe some differences in the biology. I think there's some catching up to do on the clinical research, though.
Yeah, I believe that soft wave is a form of shock wave. It's just a different waveform that you're getting with soft wave. So I think it can have equivalent effects to shock wave. It is basically a shock wave, but the waveform is from what I've looked into soft wave, and the waveform is a little bit different than our focused and radial type shock wave. But I think it could be just as effective.
We have our database, Orthobiologics, and we track 300 doctors around the country who use different machines. And I would say the results have been good in orthopedics. Now, devil's in the details, right? What are you talking about? You're talking about knee arthritis, you're talking about a meniscus tear, you're talking about a rotator cuff tendon tear, Achilles tendon, etc. And we're slowly able to collect this real world data and make some conclusions. But if we have a patient in the office, we'll just pull up the database and we'll look and we'll see what's the best method of treatment.
Yeah. Next question. What are your thoughts on proceeding with the conservative management of meniscus tear instead of meniscus repair for a younger individual? I
Yeah.
know a lot of your studies, you mentioned compare meniscectomy to sham, conservative PT, but not repair. That's a good question. If it all depends on the patient, their activity level, how old are they, and what the MRI looks like. If it looks like a significant tear, um, then I always get a surgical opinion. That's what I would recommend, getting a surgical opinion so you kind of know what the potential ramifications are of, you know, should you have a repair or should you try conservative measures first? Because there
In
is
the
that
case,
window. If you wait too long, then success rate of repair might not be as successful. So there is some uh, downside to waiting. So
I think ideally, if it was possible to repair every tear, that would be the way to go, but that is not the case. Repairing the tear does help maintain the hoop, the tension hoop stress, they call it in the meniscus, which does add stability to the joint, right? The meniscus functions in some ways similar to how a labrum in your shoulder or your hip might function, where it's creating some additional stability to the knee joint. And without that stability over time, those micro motions can lead to accelerated degeneration of the joint. So theoretically, if it were possible to repair that meniscus and preserve that physical stability function, we would do that. It's just not possible in the older degenerative case. So a lot of these studies are looking at the more common scenario, which is anybody over 50 with the degeneration of the meniscus. But yes, a good question. How would it compare in the younger patient population? That would be those. I'm not aware of studies that have done those head to head. So the proliferation of adipose tissue is another proved. So they're asking about growing cells in culture. So yeah, so I just told you that we take out the adipose tissue, grow it in culture, increase the number to tens of millions of cells, which is necessary for some patients. The lower doses are not sufficient. You can research, you can go Google my name. You'll find that I've published a couple papers with some co-authors looking at the MFAT procedure for knee osteoarthritis, showing significantly high success rate, up at 85 to 88% of patients with severe knee osteoarthritis doing well, even with just 1 million mesenchymal stem cells. To be fair, when we're injecting fat, or even bone marrow for that matter, into a joint in the clinic, there's no real way to count the cells. The only way to count the cells would be to do it in conjunction with a lab. Most doctors' offices do not have that technology available. So sort of an unknown dose in those studies that you'll read. But we know on average, patient probably gets about 1 million mesenchymal stem cells in an MFAT procedure. It could be higher. It varies widely. I've seen as low as 200,000 cells per gram. I've seen as high as 1 million cells per gram. It varies widely, and it's not necessarily correlating with age. Genetics and lifestyle play a huge role in the density of mesenchymal stem cells in the adipose tissue. So that's something that we've measured and something you can read about.
Next question. Are you familiar with low dose radiation therapy? If so, what do you think about it? I'm not familiar with low dose radiation therapy for meniscus tears yeah.
I'm not sure what that refers to. Radiation with X-ray?
Yeah, I haven't heard of that treatment for
Intriguing. I
orthopedics.
guess we have some reading to do tonight.
Yeah.
You know, what about fresh MSCs from cord blood? So I just shared with you, Ed knows what I'm going to say. So I just shared with you that there are no FDA-approved stem cell therapies in the United States. I know there are doctors who offer stem cell therapy. When I say stem cell, I'm not talking bone marrow aspirate concentrate, and I'm not talking about microfragmented adipose tissue. I'm talking about cells that have been grown in a lab. So tissue was harvested from a donor, and then it was grown in the lab and then administered at a future point. And currently, that's not permitted. Doctors are not supposed to be doing it, and yet we can name about 24 clinics in Southern California alone that do it. The reason why we don't support it is because those products have not been tested for safety. And without safety data, I'm not going to subject my patient to anything that hasn't been proven to be safe. So with PRP, we have abundant data. I mean, between Ed and I combined, we've probably done 15,000 PRP injections in our career. We know the data is good. The published data is good. With MFAT and BMAC bone marrow, we've seen similar safety. With cultured stem cells done properly, with the lab that I work with, personalized stem cells, we have safety data there as well. But on these donated umbilical cord blood, the Wharton's jelly, placenta, some of these donor tissues, they are not studied to the same degree to be safe. And frankly, doctors should not be giving them to patients.
Okay.
You said a million stem cells is nothing. Well, read my published papers, and I assure you that you can get a very good clinical benefit. It's not about number necessarily, always. Okay, so low dose radiation therapy, we're just reading what someone put here, is a non-invasive treatment using very low radiation levels. Okay, we're going to have to read more about that to give you an intelligent
Yeah, thanks for
response.
the info.
Yeah, appreciate it. We always love hearing about new things, whether it's peptides or exosomes, what have you. We will review the literature and then we'll give you our professional opinion as to whether or not we think this scientific evidence warrants you subjecting your health and your financial health to these treatments. What is the cost of proliferation? Okay, go to personalizedstemcells.com. Anybody can bank their cells today. Full disclosure, I'm medical director for the clinic, and I also have banked my own cells. So any patient today can have their adipose tissue collected through a simple lipase aspiration procedure and then have their cells banked. But you can't get access to your stem cells until we have FDA approval, or if you may qualify for some of the early access programs, which we've talked about in other lectures. We have 9 minutes. Any more questions about the meniscus? Did anybody have an arthroscopic procedure that maybe did very well? I know plenty of patients who do well, just concerned that for the ones who don't need it, those are the patients we want to treat. Patients who can, everything in medicine is about doing as little as possible, right? So if you have a big surgery, is there a way we can get you better with a little surgery? If there was a little surgery, can we get you better with a simple injection? Try to do as little as possible to improve the symptoms and function without affecting safety.
Okay, I think
Do you
that's
have a
about it.
meniscus tear? Do you have a meniscus tear, doctor?
I did.
You have knee osteoarthritis.
Yeah, I have arthritis and I tore the meniscus. So I had a distinct pain right on the lateral joint line. I knew it was something different than usual. And it was a tear that was displaced. Part of that anterior horn of the lateral meniscus had kind of flipped over. And I elected to try and have it repaired, even though the surgeon said there's low likelihood of that he could repair it. But
Yeah.
I had loose bodies that I had wanted to remove anyway, so I underwent the surgery. Unfortunately, he couldn't repair it, so he just shaved off that little piece that was unstable and flapping around. And so that pain went away. But after the surgery, it was actually a much longer recovery than I expected. I had more pain from the arthritis after the surgery for 3 to 4 months. And I was getting depressed. So I finally did the PRP injection 3 or 4 months after the surgery, and luckily that worked. So I'm doing good now. So
Do we have something in common? I've also had PRP in my knee for my meniscus tear, but I did not have the problems you had. I did not have I didn't need the surgery. I had clicking. Weirdly, I did have clicking when I walked. My knee would click. It wouldn't lock. About 3 or 4 months after the PRP treatment, that clicking went away. So it might have just been some swelling of the tissue. I don't think that meniscus stabilized itself, but I think that just the inflamed tissue probably, improved. So obviously we're treating ourselves as we would treat you. So anyway, I'd like to thank everyone for joining us today. Thank you, Dr. Evangelista, for a great presentation. I learned a lot. I hope everybody else learned a lot as well. We do this every month. You're welcome to join us, and you can see all the previous videos on our YouTube channel, as we mentioned. Any questions, feel free to email or call. And thank you for taking the time.
thank you, everyone. Have a good day.